this is data that's just published by the American Society with the number of cancer deaths per year over time. And so the men are on the top and the women on the bottom right. And you can see each color represents a different type of cancer, and red is lung cancer. So you can see it really, there were very few cases of lung cancer several decades ago. And then you can see that huge peak where lung cancer was by far the most common cause of cancer death. And then this is women here, very low, and then a smaller peak. So maybe I'll actually start by asking some questions. What do you think caused that peak? Smoking. So we didn't have smoking many decades ago, and men generally smoke more than women. So you can see that huge peak from men smoking. And thankfully, around this time, we realized that smoking causes cancer, particularly lung cancer. And look at how much it's fallen since anti-smoking measures have been instituted. Now, women had a smaller peak, and women seem to be quitting smoking a little bit slower. And so that peak, thankfully, is lower. However, it's still the most common cause of cancer death. You can see it's still the highest, even though it's a lot better than it was. So if you take all of the deaths every year due to cancer, lung cancer causes 20%. So it is still the leading cause. And that is because lung cancer is usually diagnosed when it is quite advanced. So for every type of cancer, we divide it into stages depending on how far it's spread throughout the body or how big the tumor is. So this is my schematic of lung cancer staging. So 1 through 4, on the left, this is an early stage lung cancer. And you can see the pink ones here and the tumor I put in neon green. And so stage 1 really means a small tumor that does not spread anywhere. For stage 2, the tumor is spread to lymph nodes, but somewhere really close, usually in the same lobe of the lung. Stage 3 means that the cancer has either grown quite large or it's spread to lymph nodes that are a little further away. So you can see them in the middle of the chest here. And then stage 4 means metastatic cancer, when it's actually spread to another organ in the body. So some of the more common organs that lung cancer can spread to are the brain, bone, adrenal glands. So the reason why lung cancer is usually diagnosed later is because that's when it actually starts causing symptoms. So someone with early stage lung cancer with a tumor, a small tumor in the lung, they probably have no idea that it's there. They have a lot of normal lung that can work just fine. Their breathing is fine. They're feeling well. But you can see as the tumor gets bigger or it spreads, then people start having symptoms. If the tumor is really big, it can press around in the airway and cause a cough. If it grows into a blood vessel, people might cough up blood. If it spreads to the brain, people can have headaches. Or if it spreads to the bone, let's say it spreads to the spine, someone could start having back pain. And you can see these are all pretty common symptoms that people have for many reasons. So if they go to a doctor and say, I have a cough, it might take a while to actually figure out that it's lung cancer instead of many of the other common reasons. So most people are diagnosed in these stages 3 to 4. And that's when it is much harder to treat and cure lung cancer. And so this talk today is really about screening, how we can diagnose people in these stages where it's still quite early and easier to. So as the slide says, early detection is key. And I just wanted to review what this term screening means. And that means looking for a disease before it causes a disease. So we have many examples of other types of cancer that have been around a lot longer than screening. I don't want to get too personal, but does anyone either have a mammogram or know someone? Okay. How about colonoscopy? Be a little more difficult, yes. Pap smears for cervical cancer. Okay, so these are all types of cancer screening. That means looking for these types of cancer before they cause any symptoms so that we can diagnose them and treat them while they're early. So we really need a way to diagnose lung cancer. And then I just had to stick this picture in here. This is my operating room. And a lot of people ask, well, why is a thoracic surgeon talking about screening? A lot of the times it's in the realm of primary physicians. But really, as a thoracic surgeon, I can treat and cure people when they have early stage disease. So the whole aspect of lung cancer screening and finding lung cancer early means that I can. And so that is one of the reasons why I've been involved in our screening. So how do we detect lung cancer? So we talked about mammograms for breast cancer, colonoscopy for colorectal cancer. For lung cancer, it's a CT scan, and in particular, it's called a low-dose CT scan or LDCT. And you can see the picture of a standard CT scanner here. This is a pretty common test these days. Has anyone gotten a CT scan or someone who's gotten a scan? And if you feel comfortable sharing, if you've gotten a scan, did it hurt at all? I don't say it didn't hurt. Was it pretty quick? Very, very quick, yeah. So these are painless. This is a pretty fancy technology that uses x-rays from different directions to get a really detailed picture of the lungs in there. And so any abnormality in the lungs, we can see it using this LDCT. And as I said, so there's no contrast needed, no IVs, no needles. You actually don't feel anything when you're lying down in the scanner. And they'll ask people to take a deep breath in just so that the lungs are moving when they're scanning. But it scans so quickly that you just take a deep breath in, hold your breath for a few seconds. All right, so the big question for lung cancer screening is who should get screened? So in other types of lung cancer or other types of cancer screening, it's a little bit more straightforward. You're 45 or older, get a colonoscopy or other colorectal cancer screening. For mammograms, it's 40 now, recommended by the United States Preventive Services Task Force. For lung cancer screening, it's a little bit more complicated. It's based on that fact that smoking is the biggest risk factor for lung cancer. So currently, it's only heavy smokers who are recommended to get lung cancer screening. And so these are the current recommendations by the United States Preventive Services Task Force. And because they are the ones that guide Medicare and insurance, this is what is currently covered in by insurance. So it's people who are aged 50 to 80 years old. They have a 20-half-year smoking history. And then they're either current smokers or they quit within 15 years. And one of the reasons for that is because we know that the risk of lung cancer decreases the further out you are from quitting smoking. So smoking cessation or quitting smoking is also a really big part of our recommendations for people for lung cancer screening and prevention. So the recommendation is getting that LDCT every year for. So one of the questions I get a lot, and this is something that we use very commonly in medicine, to quantify how much smoking exposure is. And so we calculate it by multiplying the number of times smoked per day by the number of years smoked. And so this is an average. So we have a couple examples. You know, advance a couple times. So the criteria for screening is 20 tap years. And so, for example, if someone has smoked 1 pack per day for 20 years, then you multiply that and you get 20 packs. But there are a lot of different ways you can get to 20. So to advance one more time, for example, if someone smokes more, 2 packs per day, then it would only take 10 years of that smoking rate to get to 20 packs. All right, and so I just thought I'd give you a little bit of history about how we came up with these criteria. The National Cancer Institute from our government put on a huge trial looking at screening many years ago. It was in the 2000s that they did this. And it was called the National Lung Screening Trial, like NLST short. And they enrolled over 50,000 people across the US. So people who had that heavy smoking history they actually, to qualify for that trial, had 30. These are people who really who have a lot of smoking exposure. And then at the time, they also made the age cutoff. So these were the original criteria. And you can imagine they found 50,000 people who met those criteria, and they asked them to join a trial to advance, and then they randomized them. So they randomly assigned them to either getting the LTCT for 3 years or just a plain X-ray for 3 years. So an X-ray is just one shot. You get one picture of the lungs versus the CT scan where you get many slices and a lot of detail. Well, they wanted a fair comparison rather than just saying, live your life. So they checked up on people every 3 years, and then they saw how many people were diagnosed with lung cancer, how many people died from lung cancer, what were the characteristics of it. And then they found that people who were in the LDCT group, they had 20% fewer deaths from lung cancer over those 3 years. And we talked about the stages and how most people are diagnosed in the later stages. For the group that got the LDCTs every year, half of them were diagnosed at stage 1. So this was huge. We did not do any screening beforehand. We didn't recommend anything. We just diagnosed cancer late. That's just how it worked. But after this trial, that really set everything in motion, where the government started recommending screening for heavy smokers. The insurance companies started covering it. And that's really the start of all of our lung cancer screening programs today. Now you can see that we've refined the criteria a little bit. So this is really hard to do, and it took many years to find 50,000 people and study them over many years. But with some modeling about who gets lung cancer, they've expanded the criteria a little. So these criteria were actually the original ones that were recommended back in 2013. But then in 2021, they expanded the criteria that we just reviewed. So a little bit younger and people with a little bit less smoking history are now included in recommended. So this is an example of a CT scan, or what we get when we do the LVCT. This is actually a recent patient of mine who had a long smoking history. And this is an example of what we get. So this is, imagine that he's lying on the scanner like this, and then we're just taking a slice. And this is one slice of 100 or more that we get. And every few millimeters, we get a picture just like this to look at the lungs. So these are the 2 lungs here. They're in dark gray. The CT scan, just like X-rays, all relies on density. For the lung, they're mostly filled with air. So they show up really dark. Just like the air outside the body, the lungs are air. But then you can see the lungs have some structure in them. So they have blood vessels and airways that run through. So when you see these little white dots here, those are all normal blood vessels. They didn't want to spot the tumor. See a few nods, so I think you see it. So this is a small lung nodule right here. And this one measured about 1.5 centimeters, so still quite small here. And just like I said before, he was not having any symptoms at all, felt normal, but went in for that screening scan because he met the criteria of the smoking history and age. And so when this was found, he came to my clinic, and then we evaluated this, and we actually got a biopsy. So they put a little camera through his mouth and into his lungs and took a little sample of this. And they found a type of cancer that we call adenocarcinoma. That's the most common type of lung cancer that we diagnose. And so after a few more tests, which showed that this was likely stage 1, we took him to surgery. So I removed the nodule and a little rim of normal lung down there, and got to keep most of his lung because it was early stage. And so he doesn't require any other treatment. And we're just doing CT scans now for surveillance after lung cancer.
Yes, I have a question. The bronchoscopy.
Yes, yeah, they're asleep. There are a couple of different ways to biopsy a lung nodule. So we could go from the inside with the bronchoscopy. People have to be asleep for that, otherwise. There's another way to do it with little needle and usually people are just a little bit sleepy for that, but still awake. and they numb up the skin, and it's very easy. Yes.
This patient had a previous scan, and so
No previous scan. Yeah, no reason to get a scan before the screening. Good question though, because these days we do order a lot of scans for different reasons. So sometimes people have a previous scan where we can compare, and that can be really useful to see whether something's there.
so the patient is cancer-free.
Yes, yes, because of screening. All right, this is a busy slide, but I just wanted to explain if anyone does undergo a screening CT scan, this is how the radiologist will classify the results. So it's a program called LungRADS, and this is by the American College of Radiology. And every lung nodule that you see is classified depending on how suspicious it is for lung cancer. So on the report for the LVCT, every nodule will be assigned one of these LungRADS numbers from 0 to 4, depending on how suspicious. So I know this is really small. I'll just read one example. So for example, LungRADS 2 means that it's probably a benign nodule. So they don't think it looks like lung cancer. And they estimate that a lot of people have these, 45% of the population might have a tiny lung nodule that's either due to infection or inflammation, and the worry is pretty low that it's cancer. So the recommendation for LungRADS 2 is a scan in 12 months. So they're saying there is this abnormality there, but it looks so normal enough that you can just continue with the annual screen. Here you can see LungRADS 3, probably benign, but they're less sure. So this for someone who has LungRADS 3, the recommendation is get another scan in 6 months. So then if it's growing, then it raises our suspicion. So we're not letting it go the full year without checking. LungRADS 4 are the ones that are very suspicious for lung cancer. And you can see the recommendations are more aggressive. So it's either get another CT scan in 3 months. You don't want to wait a long time before you figure out if it's growing or changing. Or getting a PET CT, which gives more information about the nodule, or even biopsy. So the bronchoscopic biopsy that we mentioned, CT-guided, percutaneous biopsy, or sometimes even surgery. If it's suspicious enough, I will talk to some patients about whether we should just get it out, because if we are not going to trust a biopsy, if it's looking so suspicious on the scan, we might decide actually to go to surgery. So we do have to talk about the risks of screening. So sometimes people will ask, well, should I just screen everyone, right? Because we could get an LDCT for everyone starting at a very young age, and then we would never find one. And that would be really amazing. I could retire and we could just, we could flatten that red curve completely. But there are some risks and some reasons why we don't want to just have everyone do that. So one concern is the radiation exposure. This is more applicable for people who are younger, who have time radiation exposure to it. So the LVCT right now is that the radiation is about the same as 6 months of background radiation. Us just living at sea level, it's about 6 months of that, or about 50 cross-country flights. So every time we fly, we're exposed to radiation. So it's not considered a lot for people where the CT scan is important. We get scans all the time. But it is one concern for why we don't want to start scanning people really young and have them accumulate a lot of unnecessary exposure if their lung cancer risk is very low. Another risk is a false positive. So that means that we find a lung nodule, we're worried about it, and people might get either initial scans, biopsy, sometimes even surgery for a nodule, but then it turns out to be what we call benign. And so that person would probably have either unnecessary tests or procedures, or even just the anxiety of thinking about it. And the more that we screen people at lower and lower risks of lung cancer, the more that nodules are going to be benign, and they're at higher risk of having these false positives. The third risk is an overdiagnosis, and we don't have a good sense about this one yet, but that means that we find the lung cancer, but let's say the person's very old with other medical problems, or the lung cancer is so slowly growing that it would never, and we don't have a good sense of how many of those types of lung cancer there are, but we do know that some lung cancers are quite indolent, they grow slowly. So if we find a lot of those cancers with screening and we treat them and we pat ourselves on the back because we feel like we're diagnosing a lot of lung cancer, treating them, but actually they're very slow growing, then we've actually just created a lot of medical care without decreasing mortality or decreasing the lung cancer deaths, which is our main goal. So that one, I think we're still learning about how big of a factor. And then the last two are also extremely important. The cost of the LDCT. Now, for people who have insurance and qualify and meet those criteria, insurance covers the LDCT. But there is cost, if there's co-pays for reviewing the CT results with your physician, and then the cost to our medical system in general. So I think that's one reason why we're not advocating for everyone to go out and get an LDCT, but just people with higher risk. And then finally, anxiety. That is a huge part of it. All of my patients who come in to review scans are very anxious to get the results and review parts of the report that go into detail about every slight abnormality on the scan. And that is a huge deal as well. And, I've seen people, we reviewed the lung RADs, but if you have a lung RAD that's probably benign, it's kind of hard to know how anxious to be with those results. And so I think anxiety is a big factor that we have to take into account when recommending books. Now, in the US, lung cancer screening was officially covered by insurance starting in 2015, so 1 decade ago. But we are doing a really bad job actually implementing lung cancer screening, which is one reason why the Stanford Cancer Institute is hosting events like this to really spread the word. So this is a map of the United States, and each state has a color depending on how good they're doing lung cancer screening. And so you could see this is representing the percentage of people who are eligible who are actually getting screened. So California is in this kind of dark teal color. We are around 16%. So that means of the heavy smokers who qualify for lung cancer screening, where it be covered with insurance, only 16% of those people are actually getting screened. So this is really terrible. And you can see we're not alone. Across the whole country, screening rates are quite low. Some of the largest ones over here are just in the 20s. So we have a lot of work to do to make sure that people who are eligible. Stanford puts on a community health fair every May called Health Matters. And a couple years ago, we surveyed people who were attending the health fair. And we asked, do you know that there's a way to screen lung cancer? 71% of people said they did not know. So I think it's really important to spread the word. If you know someone who smokes, let them know to talk to their doctor. Now I'll just add one slide about people who don't smoke, because this is a big question that I get as well. And in the Bay Area, our smoking rates are low, so a lot of times people ask about this. And we know that the proportion of people with lung cancer who don't smoke is increasing. We don't really know if the risk of lung cancer for those people is increasing, partly because it's really hard to get this data. It's hard to know. We went through the calculation of half years. Very hard to do that for every single person and know the risk. But we do know that as smoking rates fall, just of the people that are diagnosed with lung cancer, there's a higher proportion of people who never smoke. And so for those people, lung cancer screening is generally not. The USPSTF, which sets the guidelines for what insurances will cover, they don't recommend any screening for people who don't smoke. There are a couple other cancer societies. There's one called the National Cancer Preventive Network, also the American Cancer Society, where they have certain criteria where they'll say, actually, screening might be helpful. But we don't have a similar 50,000 people trial to base that guidance. So I think it is a very conversation with your doctor or a lung cancer to discuss whether it's worth the risks for each individual person. So other risk factors that aren't in the guidelines, we believe that they contribute to lung cancer. Well, I'd say secondhand smoke, we know that does. So if someone has a very, live with someone who smokes a lot, it's worth talking to your doctor. Environmental and occupational exposure, some of the more common ones that we know are radon, which is the gas emitted from radium. Asbestos exposure is a risk. Then there's some others that are the data is included. So a lot of people have asked about fumes, and there have been studies done mostly in China looking at people who use wood or coal burning stoves. That is much less common. But I do just recommend if you're cooking on the stove to make sure that the vent is on, your window is open, so you're not in different. But it is, I think, all of our kitchens here in general are very different ones that were studied with wood or coal burning, which is a known risk. Lung disease like COPD that can also be caused by smoking, or tuberculosis is a risk. And then finally, family history. So that means having a family member with lung cancer, that is also. So right now, we don't have any genes that we know to test for, like in other types of cancer, for breast cancer. There's a gene we can test. For lung cancer, it's really that we know people with a family member with lung cancer, especially if they're a close family member, in particular a mom or a sibling, that those people are at higher risk. Yes.
I just want to get Asian non-smoker has practiced lung cancer.
Yes, yes. That is true with our limited data, but it is very true, and especially Asian women. And this does seem to be in Asia as well as Asian Americans. We know for cancer registries, if we look at people who were diagnosed with lung cancer, if we look at the general population in the US, it's only about 20% of people who've never smoked. But if we look at Asian American, especially women, Asian American women who are diagnosed with lung cancer, it's a much higher proportion of that. It is a little bit different than the distinction of what the risk is. And so there are fewer studies that show us the absolute risk. Those seem to suggest that it is higher for Asians and Asian Americans. Still lower than people who have smoked, but higher than, for example, the white groups that were studied in those populations.
I'm just worried.
Yes.
To multiple bouts, including at risk.
Not that we know.
All right.
All right, so to finish off, I just wanted to go over the criteria again and say that if you are concerned, if you meet the criteria for sure, if you're concerned about lung cancer, want to do screening, talk to your doctor, and then spread awareness. So if you know people who smoke, if you have friends or family or anyone, share this information. So we'll review the criteria once again. It's currently recommended just for heavy smokers, so people 50 to 80 years old who have at least a 20-year smoking history, who are either currently smoking or quit within the last 15 years. And it's really an annual LDCT. It's not one and done. It is every single year in case a nodule grows, we want to catch lung cancer early. And then one more plug for smoking cessation. So quitting smoking also really just as important getting these LDCTs to decrease the risk of lung cancer as well as the